Good evening, everyone. Welcome and thank you for joining us for this year's Royal College of Pathologists BDIAP Foundation and Undergraduate Taster Event. I'm Angharad Davies, Vice President for Learning at the college, and before this I previously had the privilege of being the college lead for Foundation. This is now our 5th taster event, so I'm delighted to be able to welcome you here again this evening. It's fantastic that so many of you out there are interested in finding out more about the pathology disciplines. You'll notice that your microphones should be muted and your videos are turned off because we're in the webinar format to allow for fewer distractions. You'll be able to ask questions later in the Q&A session through the Q&A function in front of you during the panel discussion. And if you're using Twitter, we're using the hashtag #WeLovePathology. So this slide shows you the programme for the next hour and a half or so. First of all, we'll hear from the college president, Professor Mike Osborn, to explain why pathology is such a great choice of career. After that, we will be introducing some of our opportunities in Foundation and hearing from one of our current Foundation Fellows, Dr. Josh Thomas Parr, and one of our longitudinal integrated Foundation trainees, Dr. Taran Kular, about their experiences in pathology. We'll then hand over to Dr. Matt Clark, who's current chair of the Academy of Medical Royal College's trainee doctors group and a specialty trainee in diagnostic neuropathology. And he's going to talk you through an interactive mystery case, which will give you a taste of several different pathology specialties. Dr. Rachel Rummery, Vice Chair of the RCPath Trainee Advisory Committee, will then chair the Q&A panel with all our representatives from different disciplines who I'll introduce you to in a minute. You can ask anything you like through the Q&A box. I hope most of you had the chance to watch the specialty videos which you were interested in, which panel members prepared, and the Q&A is your opportunity to ask questions about those. We'll then have a short presentation on behalf of the BDIAP, our sponsors tonight, who we're very grateful to for sponsoring this evening. And then we'll have some advice on how to organise a taster day local to where you are in a department that you'd like to visit, and a bit of information on the competitions and awards that we run, which are open to medical students and Foundation doctors. These are our guest panelists participating in the Q&A panel. We're really grateful to all of them for finding time to join us tonight, and also to them and all the others who have produced the videos which you'll have watched in advance of this event. So from chemical pathology, we have Dr. Jessica Johnson. From hematology, we have Dr. Dana Warcel and Dr. Erblich. From histopathology, we've got Professor Mike Osborn, College President, and Dr. Dilek Tays. For neuropathology, we've got Dr. Matt Clark. For immunology, Dr. Anne Boulton. And for the infection specialties, we have Dr. Ian Blythe and Dr. Isabel Ramsey. Now, this word cloud is one that we formed from words which Foundation doctors and medical students have told us that they associate with pathology. The bigger the word, the more often it was cited. And what really stands out alongside the diagnosis and the detective type aspects is a very strong reflection of the intellectual aspect of pathology, with words like research, science, academic, analytical. It's good to see that these continue to be highly valued and by our potential future pathologists. And it's also good to see words like diverse and varied, because we are a very diverse bunch of people in all sorts of ways, and with a hugely diverse range of work as well. So now I have the pleasure of handing over to our president, Professor Mike Osborn. Mike is a consultant histopathologist at Imperial Healthcare NHS Trust, where he's clinical lead, and he divides his time between postmortems, diagnostic work and teaching, as well as being college president. We're really grateful, Mike, that you've managed to squeeze in some time to join us this evening as well. Thank you.
Thank you very much for inviting me. I'm going to try and share my screen. Hello, yes, thank you very much for inviting me. My name is Professor Mike Osborn. I'm President of the Royal College of Pathologists. I also happen to be Secretary of the BDIAP, so you get two versions of me today, but I'm here really as President of the Royal College this evening. And my job is to tell you why pathology is such a great career. And unfortunately, I've only got 10 minutes to do that in, and I could probably spend 10 days or 10 years telling you how fantastic it is, because we have got so many specialties. 70% of every healthcare interaction in the world involves pathology of one sort or another. So pathologists are absolutely central to every type of healthcare. And if you think, oh, that can't be right, just think of the times you have been to the doctor, where everything from a throat swab through to a blood test, all of these things are pathology and are done by pathologists and involve pathologists. So we're hugely involved in healthcare of everybody, from before you're born, essentially until even after you die, because post-mortems are pathology as well. So pathology offers a whole range of specialties, and the thing that means is that there is a huge range of choice within pathology itself. And as a result of that, there really is a career that is something for everybody. There is something that anybody, whatever your interests, whatever your aspirations, whatever you want to do, there is something for you in one of our specialties. So just giving you a taste of our specialties, there's pages about all of this on the website, which I'm sure you've seen and are available. There's everything, you know, covering toxicology, chemical pathology, through to things like forensic pathology, histocompatibility, neuropathology. Histopathology is obviously one of our big ones, microbiology, virology, many of these you're hearing about tonight, but all things to do with blood transfusion, hematology, pediatric and perinatal pathology. There are a vast range of pathology specialties, so there really is something for everybody. We even cover animals as well. So we have veterinary pathology in a variety of forms, and they're a very active part of our college. So we cover everything. And we also are a college that not only has medically qualified members, but we also have clinical scientists as well, because many of our laboratory-based specialties are very, very well evolved for clinical scientists to take consultant roles as well. So I'll come on to some of this, what this means later on. So there really is a huge range of things in pathology, and that means that there is something for everybody. Now, whatever you want to do, there is something for you. Some of our roles involve a lot of patient contact. So, for example, hematology, where people can run hematology clinics and see actual patients in the clinical setting, essentially in a physician-y type way. Microbiology, similarly, with ward rounds, ward work, all of these sorts of things around, largely around infection control, antimicrobial stewardship, and so forth. So really, really patient interacting, and things like immunology, where the basis of their work is often clinics and so forth. So that is a very, very patient-focused part of pathology. So if you're patient-focused, there is something for you. Other people are not such big fans of direct patient contact, and there are other specialties. So, for example, histopathology, forensic pathology, where you have much less direct patient contact. So there's whatever your aspirations about patient contact, being patient-facing or not, there is certainly something for you in pathology. So this is what a histopathology lab would look like, but you know, it's not all looking down microscopes. Most of histopathology is like that, though. We are moving towards digital, but our other specialties maybe involve clinics and patient settings and so forth. Pathologists of all our specialties are very, very involved in research in the clinical setting or in research institutions like university or industry. This doesn't mean you have to be involved in research, but what it means is pathologists are always in demand for research. So if you are interested, there are huge opportunities, probably more than in almost any other specialty, to be involved. And pathologists in those areas work to develop, for example, new tests, new treatments, and new drugs. So there's a huge research opportunity for that. So this is just, again, some pictures. This would be histopathology. I'm sure you'll hear more about this later on, cut up slides. processing of tissue, but it's not all necessarily about the laboratory. Many people do clinics and so forth. So again, a huge amount for people to do in a variety of ways. But pathologists, as I've said, even if they're not directly involved in research, they're always very much in demand for research. And as a result, it's an excellent way to get into academia if that interests you. But even if you want to be a diagnostic pathologist and not so academic in terms of research, projects come up that you can be involved in. And so it's an opportunity, it's a specialty that allows you to cherry pick your involvement in research if you want. And that really is something that many other specialties in terms of medical big specialties do not offer. So the research options are there and are really an exciting part, but not necessary if you don't want to do them. So again, just some microbiology. You know, there's so many different ways that pathology interacts either with patients or in a laboratory setting or in combinations of both. Other things that pathologists are very much involved in is undergraduate and postgraduate teaching of medical staff, but also of allied professionals as well, be they those closely allied to pathology, so involved in pathology themselves. So, for example, our clinical scientist colleagues that I've spoken about already, but also biomedical scientists who are laboratory staff, but even broader allied professionals. So, for example, nurses, dietitians, physiotherapists, all of these people often have aspects of pathology they need to learn about, and we are involved in teaching them, pharmacists and so forth. So very, very huge opportunities involving teaching as well. I do a lot of teaching, both undergraduate and postgraduate, and through my teaching work, I've even come to run a humanities BSc at Imperial College. So there really is a huge range of opportunities that come up in pathology. I have to highlight, I also run it with some clever humanities people, so it isn't just me. But, you know, what I'm saying is it really does offer opportunities that perhaps other specialties don't, because it underpins so much pathology. And you get to interact with lots and lots of other clinical people, because most of our specialties will be dealing with them, for example, in multidisciplinary teams and so forth. So you have a very close relationship with other clinical members, be they surgeons or physicians or allied professionals, nurses and so forth, on a very regular basis. So you're not working in isolation, you're definitely part of the team, and that's one of the really good things about it. Many pathologists combine several aspects of this into their job in a sort of portfolio career. So, for example, they may do lots of diagnostic work that may include patient-facing clinics and so forth, but they may also do some research, and they may also well do some undergraduate teaching. And they may have a combination of those things that really makes the job much more interesting and much more varied and enjoyable. And that's something pathology really lends itself to, whichever of our 17 specialties you would choose to do. Other advantages of pathology, there are lots of jobs in most of our specialties. So whether you want to do microbiology or clinical chemistry or virology or histopathology, there are lots of jobs available, which means you can pretty much work wherever you want in the United Kingdom or indeed in the world. Because there's a large international demand for pathologists. We are a very, very family-friendly specialty. All of our specialties are family-friendly and work-life balance friendly, and as a result of that, it is a really good specialty to do. Because you know that is an important factor and makes work much more enjoyable and much more doable on a day-to-day basis. And indeed, we're very good at supporting flexible working and things like working from home, obviously depending what your specialty is. So things like that, which increase the flexibility, increase the ability for people to do it who've got families or got other commitments, care-wise and things like that. It's a really, really good specialty for that in whichever of our specialties you choose. And also remember, given the varied type of our specialties, there will always be one that may fit with your particular family needs or whatever they may be. So again, it's very, very useful in that way. And because of that, pathology tends to have a very good work-life balance in comparison to many of the other specialties. And this is very, very important, particularly with things like retention of staff and so forth. but work-life balance tends to be very good in pathology, much better than in other specialties, and that's based on some of the things I've described above. And as a result of all of those things, pathologists tend to be happy. Now, you may go to the pathology department and think they're not actually that happy when I see them, but actually, if you speak to people, they tend to be happy, and they tend to be a lot happier than many of our clinical or other colleagues. So pathologists happy with a good work-life balance in all of our specialties. So it really is a good specialty to pursue, whatever your family commitments or aspirations and so forth. So what do we offer our trainees? Well, there's a huge package on the website for trainees, whatever your specialty, that involves supporting our trainees, developing their training and assessment, involved in examinations, obviously, but training people up to examinations, supporting them, working with deaneries and so forth to support trainees, make sure they're doing examinations at the right time to make sure they maximize chances of success and so forth. But we really spend a lot of time and a lot of college resources around training, assessment and so forth. And because of that, a lot of, we get very good feedback from our trainees. And indeed our trainees, as Matt and Rachel can say, I hope, they have a huge input into everything the college does. We're very much not, there's the trainees and the consultant body. It's not like that at all. Trainees are absolutely integral to us, and they have input into all of college activities and so forth through their trainee committee, who are excellent and who we listen to very closely on whatever the issue may be, and involve them in everything. So we're very, very trainee based, and we really do support our trainees. So training in pathology, whichever of our specialties you choose, is a pleasure. And the final thing I say is we have got a dedicated online portal that helps pathology trainees with their learning, feeds into their various portfolios of training and so forth. And this is funded through NHS England and supported by the devolved nations, NHS organisations, and really is a real jewel in our training crown, because it gives an opportunity for people to support their learning and so forth. So we have got lots of support for trainees in all of our specialties, making training absolutely brilliant in the Royal College of Pathologists. So just to finish, really, whoever you are, wherever you come from, there is a role for you in pathology, and you'll be made very, very welcome in our college. We'd love to have you. We would be truly delighted to have you as a colleague. I cannot express how good pathology is, because there is something for everyone, whatever you want to do. Thank you very much. Hope I haven't exhausted you too much. I'll be happy to take any questions. Probably in the question and answer is best.
Thanks very much, Mike, for that absolutely wonderful introduction to pathology and why it is such a stimulating career. Mike will be in the Q&A session, so if you do have any questions for Mike, as he says, he's happy to take them, and your chance to ask them will be in the Q&A session. Thanks ever so much, Mike. So we're going to move on now to look at foundation and what the opportunities are to explore pathology specialties in foundation. There have been a few developments over the past couple of years, which I just want to introduce you to. One of these is the chance to undertake longitudinal integrated foundation training in pathology, or also known as LIFT. Some of you may have heard of this, or some of you may not be familiar with it, but LIFT is a foundation arrangement in which you work 4 days a week in your acute medical or surgical or other specialty, and 1 day a week in something else, in this case in pathology. And there are currently pathology related lifts in a range of specialties in Swansea, Cardiff and in Southampton, and they are really an excellent opportunity to allow people to try out pathology and get involved in a department during your foundation years whilst still doing your acute medicine and surgery and other things. And in a minute we'll hear a presentation from a foundation doctor who has undertaken a LIFT programme in pathology. Secondly, we have our foundation fellowships. This is a relatively new scheme as well, which college introduced in 2020. And this is a really exciting opportunity to foundation doctors who are rotating through any foundation post which contains a pathology discipline within it. So that could be infection, hematology, histopathology, or any of the other specialties represented by the college. You can find out more about the various benefits and opportunities open to foundation fellows on the website. An evaluation of our first cohort found that they were received very positively, with 96% of our foundation fellows saying that it had been worthwhile for them, 96% saying the fellowships would help their careers, and 66% saying that the fellowship had positively influenced their choice of career. Applications are open right now for the 2023 round with a closing date very soon, in a couple of weeks. So you've just still got time just to squeeze in your application if you're interested in this, and if your foundation rotation contains a pathology specialty. And I'm particularly pleased that we can include one of our foundation fellows in this event to share his own experiences. So first up, welcome to Dr. Josh Thomas Parr. Josh, I'm going to stop sharing now. I'm going to hand over to you, and thank you very much for joining us.
Hello, nice to meet you all. My name is Josh Parr and I'm a current FY2 trainee in South Wales. In this short presentation, I'm going to briefly outline my experience of pathology over my F1 and F2 years and the opportunities being a foundation fellow this year has presented me with. I'm still a little undecided as to what pathology specialty I would like to pursue, but I will try to apply this autumn while completing a year as a clinical fellow. Most of what I will say in this talk is applicable to everyone, but the foundation programmes in Wales are slightly different to England in that you apply for FY2 rotations a few months after starting F1. Some of the more common pathology specialties encountered in the foundation programme are haematology, infectious disease, and medical microbiology. This is just, however, a small selection of the specialties the Royal College represents as a whole. However, there are other ways to experience these specialties that do not crop up in the programmes you've selected. And I'm just going next slide. There are lots of options for completing your foundation years. There's specialised foundation programmes, formerly the academic foundation programmes, foundation priority programmes, and various opportunities within the standard programme, such as LIFT, which you'll be hearing from with the next speaker. I first began to explore the idea of pursuing a career in pathology during my first foundation year, and thus I undertook a very standard set of non-pathology orientated clinical placements. To try and get some pathology experience, I flew into the deep end and conducted a one-week taster in histopathology. The whole experience was incredibly far from the clinical medicine I was familiar with, and I was glad to have done a bit of pre-reading before undertaking the week. I tried to learn how to visually recognise the basic cell and tissue types, and this left me in a favourable position for my taster week and my FY2 haematology placement. Having enjoyed my histopathology week, I applied for the FY2 job with the haematology rotation. Haematology is more clinical than histopathology, but still has a substantial laboratory aspect to the career. During the 4 months in Heme, I tried to undertake as many clinics, lab days and audits as possible to boost my CV. If the wards were particularly well staffed on a day, rare I know, trying to join the clinic can be a useful way to experience a specialty that otherwise you wouldn't. I managed to sneak to a few lipid clinics run by a consultant clinical biochemist, another pathology specialty. A large selection of specialty application points are available for audits, demonstration of leadership skills, teaching and taster weeks. The best way I've found to build my portfolio is to gradually accumulate these over time to show a good commitment to the specialty you wish to apply to. Prior to starting my F2 year, while perusing the college website, how I spend my free time, I saw the opportunity to apply to be a foundation fellow. Every year the college makes 25 foundation fellow places available for foundation doctors who have a pathology specialty rotation. I submitted my statement and was successful in obtaining foundation fellow status. You even get a nice certificate for your portfolio. Fellow status allows you to have a login access to the Royal College website and book various educational events throughout the year. These are very interesting and diverse. I mainly stuck to and attended haematology webinars during my heme rotation. It was a good supplementary way to learn. Fellow status has also given you a few chances during the year to present at various conferences, and as you can see, I've chosen to speak to you today about my experience of pathology in my foundation year. This is a good way to improve your CV and show commitment to specialty. The college has a quarterly bulletin that is published to fellows that I highly recommend you read. It contains topical articles about what's going on in the world of pathology. This upcoming year's fellowship application window is still open till the 1st of July, and there's still time to apply for any of the eligible listeners today who are interested. It can be found with a quick search online. All you have to do is submit a 250-word statement of interest and then hope you are chosen. Here ends my presentation. Thank you everyone for listening, and thank you for allowing me to be a fellow this year.
Well, thanks very much, Josh. It's great to hear about your experiences in foundation. And just to let everyone know, because we knew we were having this event tonight, we've actually extended the Foundation Fellow application deadline by a few days. So you've got a little bit longer. I think it might be about the 5th of July now to get your applications in, but you will still have to get your skates on a bit because it is quite soon. But we have extended it from the 1st in case there were people here that wanted to apply. So now we're going to hear from a pathology lift doctor who's been doing a microbiology and infectious diseases lift in Swansea. He's actually unfortunately on shift tonight, but he's provided us instead with a recorded video. So if I could ask one of the team to play Dr. Taran Kular's video, that'd be great. Thank you.
Hi there, my name is Taran. I'm one of the LIFT F1s in infectious diseases and medical microbiology. I'm here to talk to you about what it's like being a LIFT F1 in ID Micro. So to start off with, I'm just going to talk a bit about what LIFT is. So it stands for the Longitudinal Integrated Foundation Training Program. And generally, you'll spend a day a week in a specific specialty throughout the year. So this may be radiology, GP, or in my case, ID Micro. And it allows you to gain experience and skills relevant to that specialty. And a quick note, this day should be protected time, so you shouldn't be pulled away to the wards when you're on your lift day. So for me, that looked like essentially most Wednesdays, instead of going to my designated placement in colorectal surgery or respiratory, I'd join the infectious diseases team or microbiology team for the day. What did I do as a LIFT ID Micro trainee? So I did many different things and I got a whole host of different experiences. However, the mainstay part of my placement was essentially when I was with the ID team, I joined the consultant-led round and review complex medical or surgical patients with the consultant or registrar. And I'd also attend ITU and antimicrobial stewardship rounds as part of that as well, which was also interesting. I got to attend different MDTs, such as the trauma and orthopedic MDT or the hematology MDT, and we discussed patients that were quite complex from these different specialties and provided microbiological advice in managing their infections. From a micro standpoint, I attended the bench round. So this was where we reviewed culture samples and essentially looked at any interesting cultures, particularly blood cultures, down the microscope and identified any key characteristics. And sort of looked at further sample testing like coagulase testing, which was really interesting. And just to note, I'd never been able to see anything down a microscope before this. However, thanks to the consultants and reggers who took their time with me, I was able to actually properly identify and see different bacteria down the microscope, which was definitely really cool. As well as this, I got to observe seniors providing micro advice. And I also had the opportunity to actually do this a bit myself. So I got to essentially call out clinicians who were looking after patients who had a C. diff positive result. And I was able to provide advice under supervision about the C. diff result and the management protocol that they should follow based on the clinical picture of the patient. As well as this, I was also able to essentially get involved in certain projects. And one of these, I actually recorded a podcast for the Bugs Life series, which I'll get onto a bit later. So overall, my experience of LIFT has been excellent. I genuinely cannot fault it. And I can't recommend the ID Micro LIFT placement enough. Even if you're not thinking of ID Micro, I think it's in every specialty. So there's always something to take away for everyone. And I've had a whole host of different experiences and seen different types of conditions and different patients in a wide range of specialties. So really, I think, there's so much experience to be gained and there's so much to learn from being an ID micro lift trainee. In terms of training, in my personal opinion, the training that I've received on the lift placement was better than the training I received in my non-lift rotation. And the reason for this was really the seniors I was with, the consultants and registrars, always took the time to discuss their thinking process behind what questions I'm going to ask in the history, the examination findings, and would always point out key examination findings. So I think I've seen pretty much every possible clinical sign for infective endocarditis and heard pretty much every murmur. And they would always try to explain the differential diagnosis that's going through their head and try and involve me in that process, and would also essentially discuss the management plan that they would come up with and why they got to that point, which was really interesting and really helpful and definitely built on my confidence in managing patients when I was on call, as well as back on the ward. They also took the time to answer any questions that I had and would always encourage it. I feel like it was a very different environment to being on a ward environment, for example. It was also nice having a consistent team to be a part of for the whole year. Whereas, normally you'd be rotating around every 4 months, which can be quite difficult because you have to build new relationships. Whereas being a lift trainee, essentially every week, I'd be part of the same team and see the same faces. And they were all really, nice people, very welcoming. And it was just, a really nice environment to be a part of. And I feel like personally, I've developed so many skills from this placement, from recognizing and managing different infections to treating unwell patients and providing clinical advice to healthcare professionals and analyzing and understanding different bacterial species, and then providing safe and reasonable use of antibiotics. So I just want to talk a bit about the Bugs Life podcast, which I mentioned earlier. So this is essentially a podcast series that was set up by Dr. Blythe, and he's involved Dr. Workey, one of the regs in ID Micro in Swansea, as well as myself, and Professor Davies is also involved in the podcast as well. Essentially, it's a project that I've been lucky enough to be involved in, where we're able to record short podcasts, 10 to 15 minutes long, covering key topics like meningitis, encephalitis, or CPO, and other key infectious disease or microbiology topics. And I've had a role in organising, making some of the podcasts, recording and editing the podcasts as well. If you're interested to check out the podcast, then please scan the QR code, or you can visit the Antibiotic Aware website. Or alternatively, go to Twitter at Aware Wales, or you can go on the Royal College of Pathology portal where the podcasts are at the moment as well. So please do check it out. I think it was really useful. So thank you very much. If you have any questions, then please feel free to email me. And there's a QR code to scan if you want to check out the Bugs Life podcast. Thank you.
Well, fantastic presentation from Taran Kula. I know he's not here, but I'd like to thank him for preparing that anyway. It was really, really interesting. And I can vouch for the Bugs Life podcasts being a really excellent innovation. Right, I'm now going to hand over to Dr. Matt Clark, who I previously introduced, who is going to present the mystery case tonight. So I'm going to hand over to you now, Matt. Thanks very much.
Thanks, Angharad, and great to see everybody here today. Thank you very much for joining us this evening. My name is Matt Clark. I'm a neuropathology trainee, but also the Deputy Meeting Secretary for the BDIAP, and it's a pleasure to now discuss with you a mystery case, just to highlight how the pathology specialties can work together to make diagnoses for patients going forward. So let's meet Jane. She's our patient today. So she's 37 years old. She's generally fit and well, but she's no significant past medical history, but has had a few an ongoing fever for the last few weeks, consisting of night sweats. She's also been feeling tired and has experienced some weight loss as well. And also the family they've commented that she's been feeling they commented that she's been feeling, well, she's looked quite pale as well. So naturally, she's arranged to have an appointment with her GP, who takes a history from her and notes that she's got quite pale conjunctiva and mucous membranes on examination, just on his general examination, and also that she's got a temperature of 38.3, so she's slightly pyrexial as well. and also notes that there may be a possibly enlarged liver on the abdominal examination, but decides to do some routine blood tests just to do, well, just as a routine check really, to see if that provides any clues as to what may be going on. So first of all, we've got our full blood count. So I'm going to come to I'll ask our hematologists on the call. Dana, what do you think about these? Just give us a quick thought about what you think about these results, Dana.
Hi, everyone. So as we can see, she's anemic and she's got symptomatic anemia. She's complaining of fatigue and lethargy, breathlessness. It's macrocytic. As you can see, the MCV is raised. Slight thrombocytopenia, the platelets are slightly down. With the B symptoms that Matt has described, she has weight loss, fever, and night sweats. You could think something hematological is going on, but there's other, obviously, alternative diagnosis there as well. And then the raised ESR, LDH, not specific, but does tell you that there's something going on, inflammatory process or something, she's ill essentially.
That's lovely. Thanks very much, Dana. Thank you. And now we've got some urea and electrolytes and LFT results as well. And again, that highlighted on this, we've got the ones that are abnormal are in red. So I'm going to come to our chemical pathology colleague. Jessica, what do you think about these? And is there anything else you might want to do as well or be thinking about investigating?
So it looks like she's in some sort of renal injury, especially with her low EGFR. She's got a bit of a low albumin, and we've got a raised AST and ALT here. With so chemical pathologists, we would probably add on the bilirubin and the gamma GT to complete the AFTs. If we were given the symptoms rather than just a dot in the GP history, as we often get, then we then we might also think, oh, it would be symptoms. And the poor renal function, we might we'd add on total protein and globulins, and if the globulins are raised, we might send an aliquot for immunophoresis. So it's sort of, there definitely looks like there's some sort of liver, something with her liver, but the AST and ALT, you could also be muscular in general in nature. So you'd probably also add a CK, especially if the bilirubin wasn't raised as well. With a high LDH, the bilirubin could, even if it was high, might not be liver. It might be, as the ALP is fine, it might be from hemolysis. So that's sort of what we would think.
That's brilliant. Thanks very much for your summary, Jessica. That's really helpful. So we're going back to get a bit more clinical history now. So she's a few days later, she's actually become quite clearly very unwell. And re-examination of the patient shows that her vital signs are getting worse with a tachycardia and a low blood pressure as well. And the GP now organises her admission to hospital for further investigation. So because of time, we're not going to do a poll related to this, but these are some of the things that you may think about doing in this sort of situation. So perhaps some blood cultures and viral screen, a blood film, and sputum cultures, and possibly even thinking about starting antibiotics in this situation as well. But in this case, we've got some results for blood cultures and a viral screen, and we've got blood culture result was negative to date, but we've got some results for cytomegalovirus antibodies, and the other viral screens so far have been negative. So I'm going to ask Ian, what do you think about these results? Can you give us a sort of summary of your thoughts about it?
Yeah, pleasure to do so. So I suppose when I come or I get involved in a case, you often have two sides to it. So you have the clinical history and then you have the results in front of you. And as colleagues have summarized so far, there's clearly something a little bit unusual going on in this case. So you've got an individual who's got a febrile illness associated with thrombocytopenia, transaminitis, and acute kidney injury. And the differential diagnosis for that is pretty broad. So I often start by finding out what this individual is likely to have been exposed to. So is there something pertinent in the clinical history, travel, something they've been exposed to, someone else that's been unwell, and that might give you a little bit more of a nudge. So what we've got here is we've got some blood cultures that are negative so far, but my question is often how many sets of blood cultures have you sent? What's the sensitivity of a single test? You've got CMV serology, and the slight trickiness with all serological testing is that it has its pros and cons. So this individual's got an IgG response that usually takes a fair amount of time to develop. with a positive IgM. And there is one of two things that could be going on there. So this is either a evolving G response because of acute infection, or what you've got is false positivity in the CMV IgM because it's cross-reacting as a non-specific test with something else going on. So the honest answer is that you've got a bit of work up there, but there's a little bit more to do from a history perspective, and I'm sure things will evolve.
Thanks, Ian. Yeah, so a bit more information gathering needed from your perspective for this to go forward with it, but thank you for your assessment of that. The other thing we've got here is a bone marrow biopsy. And just to point out, I mean, we can see, some of you may have seen these before, others may not have, but we can see just on this image, we can see the red blood cells. There are also some quite large looking, very blotchy purple structures there. Again, thinking about what could these be? Could they be macrophages, normal lymphocytes, histiocytes, megakaryocytes? Thinking about the normal constituents, what we might find there, but also could they be atypical lymphocytes? So I'm going to come to our immunology colleagues and hematologists. Can you help us out with what you think about this picture? Anne, do you have any thoughts, or Dana, what do you think?
Well, I might kick things off and just say, well, it looks pretty abnormal to me.
Yeah.
There's some huge white cells in there compared to the red cells. And I would be quite concerned about this and would definitely be contacting our hematology colleagues ASAP.
Thanks, Anna. I think that your first statement actually is a really important point. One of the things as a pathology trainee when you start off is knowing what's normal and what's abnormal. So I think that's a really good, even if you're maybe not so sure about what it is, identifying when something's abnormal is a key part of this. Dana, what are your thoughts about it?
Agree. These large cells look very abnormal. And I guess in the bone marrow, you do expect to see immature cells because we do see how all the blood cells mature. And so we see the different stages of maturation. But you could even describe them as blast-looking cells. They have a high nuclear cytoplasmic ratio. Some of them have vacuolations within the cytoplasm. And so we would describe them as blast-looking cells, abnormal cells that shouldn't be there.
That's brilliant. So we've got quite an atypical looking bone marrow biopsy here. And now we've got to try and work out a little bit more about what these cells might be. So we've done some stains and done some immunophenotyping of the cells. So for those who may not be so familiar with this is a set of immunohistochemistry stains. And immunohistochemistry is really useful to us because on the cell, all the cells, there are little proteins, and we can use antibodies to bind to those proteins, and they light up if there are particular proteins on the surface of those cells. And it helps us to understand what type of cell type they might be. And so we've got some results here. We can see that the cells, these atypical cells, are CD20 positive, but they're also CD5 and CD10 positive. And we've got a few negative results there as well. Anne, do you have any thoughts about this? What do you think these might be? Does this give us a clue as to what these cells might be now?
Yeah, definitely. So as you were saying, Matt, you phrased that really nicely. Immunophenotyping is really useful in identifying exactly what kinds of cells are there. But what they're also very good is identifying when cell abnormalities are happening. So CD3 is a marker of T cells, which is negative. You've got CD20, which is a marker of B cells, which is positive. So that's suggesting what we're looking at is probably B cells. But B cells don't normally express CD5 or CD10 when they're normal and healthy. So that's concerning. And also CD29, CD54 are adhesion molecules, sort of normal cell surface markers that should be expressed, and they're not there. So again, given the picture we've just seen on the bone marrow, I'd be quite concerned about potential malignancy or some abnormal process here.
Brilliant. Thanks very much, Anne. So we're heading possibly down a malignancy route. So neoplasia in such a young patient as well. So quite concerning features that we've got already. So let's see where we go next. Oh, we've got a little bit more clinical history for our patient now. So she's getting deteriorating quite significantly, complaining of headaches, and she appears more and more confused as well. She's become aphasic, so having difficulty in actually communicating and speaking properly, and then actually has a seizure that's witnessed. An emergency scan is organized as a result of that. And so this is what we've got with her MRI scan. And on the left-hand side, again, always with the things, we want to know what the normal looks like to be able to compare to the abnormal. And so the left-hand side is normal, on the right-hand side is our patient scan. And hopefully what you can see is that there is a bit of a difference in the sort of the contrast and the enhancement associated with the scan on the right. So a lot brighter and a lot whiter, possibly towards the posterior aspect, near the occipital lobe and around the ventricles as well. So quite bright sort of enhancement and quite diffuse in nature as well. So quite rather than a discrete lesion, we've got quite a number of areas that are particularly affected by this process. So again, the differential diagnosis associated with this would be quite wide. We could be thinking about hemorrhage, potentially, infection, inflammation. Could it be a diffuse tumor that's present there? Could it even be signs of degeneration as well? But again, radiology is, although that's not our specialty, we work very closely with the radiologists, depending on what specialties we're in as well, to get their input as to what imaging, the diagnosis might be supported by imaging as well. So always important to review imaging as part of our diagnostic workup. So a bit more history now. So the patient continues to decline and her conscious level rapidly deteriorates and the seizure activity continues. And unfortunately, things progress significantly so that she actually has a cardiac arrest. And sadly, despite the efforts of the resuscitation team, they're unable to resuscitate our patient. But because we still don't really have a diagnosis for this, a post-mortem is requested as it's not clear what she might have died of or what the underlying pathology was. And again, this is now the other aspect of our work. A small part of the histopathology or cellular pathology work stream is autopsy work. And so we're now going to have a look at what we might find in this autopsy. And sometimes when we do an autopsy, we are able to identify what the cause of death is by a macroscopic examination of the organs. And so the pathologist will do a routine systematic examination of the brain, the chest organs, the abdominal organs, and then we'll see, based on the clinical history, trying to identify what that cause of death might be. But sometimes it's not possible to actually determine a cause of death just by looking at the organs macroscopically. And so sometimes we have to request to take some tissue samples to look at the samples histologically down the microscope to see if that may reveal any further information. Sometimes we also need to take samples for toxicology, particularly if we're maybe thinking about whether there is any medication involved or perhaps the patient had taken an overdose. And also postmortems are changing quite significantly now. So the use of imaging to help support postmortems and actually identifying cause of death based on the imaging studies is now becoming a very prominent feature in certain areas of the country as well. But this picture here is just showing you an example of postmortem histology associated with what we see within the kidney. So you can see the glomeruli and you can see the tubular structures around surrounding these. And so this is just a normal structure we would expect to see histologically. And then the other bit of sample I've taken and shown you here is this is what brain CNS tissue can look like. So again, the CNS tissue can vary depending on where it might be taken from. So whether it's taken from the cortex or the white matter and even different locations. So it may be within the cerebellum. But the important thing again is to recognize what's normal and what's abnormal. And just on this screen, it's often quite surprising how few cells there may appear within just a small piece of the brain tissue. But you can see a variety of different cell structures here. So there are neurons, there are the very small darker staining cells, which are the astrocytes, which are the main structural components of the brain, as well as this sort of light pink fluffy material around, which is the neuropil, which are all the connections and the axonic projections connecting all the cells within the nervous system and allowing the various different functions to take place with it. So that's what we would expect to see normally. But this is what we've actually got within our sample of the brain tissue that we've got from our patient, Jane. And so this is not, if we think about what we'd expect to see normally with this is very different to that appearance. And we're actually focusing in here on a blood vessel within the brain. And normally when we're looking at blood vessels, one of the things we can always reassure ourselves is to help confirm it's a blood vessel is that there'll be the presence of red blood cells and perhaps a few white blood cells within the vessel. But what we're seeing here is something very, very different. So we're not really seeing very many red blood cells, but what we are seeing are some very atypical looking cells. So you can see the darker staining nuclei they're different sizes and different shapes compared to each other. And this is a term we call pleomorphism. And it means that the nuclei vary in their size and their shape. And that is a hallmark feature histologically of a malignancy. And the sheer number of these cells within this one small segment of the blood vessel is also quite concerning. And when looking at the brain in different regions, more of these vessels were found to contain these abnormal looking cells. So from our perspective now, we've got to try and work out what this actually might be. And so this is another sample that's been taken actually from the kidney of this patient as well. And we've done some immunohistochemistry. And I'm going to come to Dilek now. Dilek, what do you think about the result of this? With the immunohistochemistry has been done on this, and we're just focusing in on the glomerulus here of the kidney. What do you think about this?
Hi, Matt. Well, I can see that there are some CD20 positive cells within the glomeruli, which I don't think that's expected normally. And knowing that on the bone marrow that those atypical cells were CD20 positive as well, it makes you wonder, is this the same population of cells in the kidney?
Absolutely. And again, we would want to just check the H&E to see what these cells look like. But I can assure you they were very similar to what we were seeing in the brain. So we've got two organs that are affected by this. And again, the samples in the brain also stain positively for CD20 to this degree as well. So a very positive CD20 proliferation here. And as you say, correlating that with our bone marrow findings as well. But the other thing that's a great advance that's been made in pathology is molecular pathology. And so this can also be a really useful diagnostic tool to actually help us try and work out what may be the problem. And so sending a sample of tissue off for molecular characterization is now part of routine practice to try and make a diagnosis. And in this case, what was actually found was that there was a translocation and also a mutation in, well, there were two possible mutations that you could identify. There's an MYD88 gene mutation and a CD79B gene mutation that may be present in this particular diagnosis. And so these are things that you can actually do to actually help confirm what your suspicions might be. And that's the same for any malignancy or tumor elsewhere in the body. It's now routine practice really to be able to make a histological diagnosis, but also to employ molecular characterization to look for the different genetic mutations which characterize that particular disease. And in some cases, it may be treatable for a patient and they can be started on targeted therapy in order to try and treat that particular tumor. But in this case, it's trying to help us to understand a little bit more about what our diagnosis might be. So the actual diagnosis for this patient is a rare condition called an intravascular large B-cell lymphoma. And just to give you a little bit of background, it's very rare. And it's characterized by the growth of the lymphoma cells within the vessels, and it can be widely disseminated. So that's why, again, we've got evidence here of the kidney involvement, we've got the CNS involvement, but also remember the liver function tests were off as well. And so the likelihood is that the patient's liver was also affected by this process. Patients often present with very non-specific symptoms, and it can be very dependent on the organ involved. And often, unfortunately, they progress to multi-organ failure, again, dependent on which organ systems are affected by the process. But very difficult and very challenging to actually diagnose. And the important thing here is that we've got these atypical B cells within the blood vessels, but do you remember that it was identified that there were the absence of those particular adhesion molecules on the cells? That is one of the reasons why they have an impaired ability to actually, they're in the vessel, but they can't get outside the vessel, which is very different to what we see with other lymphomas that may be affecting the CNS tissue as well. So a rare, very rare condition, but hopefully, even though it's rare, it's an example of how different pathology specialties can get involved and work together through very complex cases to make a diagnosis. And again, highlights what we all do as pathologists, which is work as medical detectives to bring the jigsaw pieces together. So thank you very much for that. And now I'm going to hand over to my colleague, Dr. Rachel Rummery, and we're going to now have our Q&A session. So over to you, Rachel.
Thank you very much, Matt. Can you hear me okay?
Yes, absolutely.
Lovely. Well, good evening, everyone. Thank you very much for coming this evening. I am Rachel Rummery. I am the Deputy Chair of the Trainee Advisory Committee at the Royal College of Pathologists and also a Paediatric and Perinatal Pathology trainee. And it's a real privilege to chair this panel tonight. I'm going to start off with the first question, which is, I think I'm probably going to direct to Mike, because it's what level of normal histology knowledge would be expected for somebody applying to histopathology training, and also what kind of gross anatomy would you need to know for cut-up, etc.?
Amount of histopathology, none. Okay. an amount of sort of anatomy, very, 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 very low level medical school anatomy. Like, we would probably expect you to be able to know the difference, probably be useful to know the difference between the liver and the intestine, but beyond that, not very much at all. Most people in Tesco's meat counter will probably have about as much anatomy knowledge as you need to know. So if you can differentiate between sausages and pork chops, you will have enough. So nothing. We will teach you everything.
I'll just come in on that as well, Rachel. So that, again, when I first started, I had no experience at all, and it's a steep learning curve in your first year, but it's also an exciting one. There's lots of learning opportunities to do that. And again, as I mentioned, it's important to know what the normal looks like before you start looking at the abnormal as well. So everybody's aware of that, and so I'm very conscious of that, and everybody will support you in your early days of your training.
Thank you very much, both of you. So I would also actually second that. You don't need to know that much. It's a hugely supportive environment, and you will be supported to find out what you need to know. So we have a second question here from Brendan. So he's commenting that many of the opportunities provided by the college are aimed at medical students and foundation doctors, allowing them to better create a portfolio for application. So as somebody who, as he says, barely got through foundation years and working as a bank SHO, he says he currently has little to show for it portfolio-wise due to health reasons. So are there any resources that anyone, I think I'm going to throw this open to the panel, anyone could advise or point to so that experience can be gained specifically in pathology other than taste it days and interacting with the local pathology department? So would anyone like to take that question, please? Mike.
Yeah, I'm going to answer your question with what you say other than. So taster days and the local department is the key, really, because they will be able to provide you with opportunities that you can then use to fill in your portfolio and support your portfolio. So the one thing I would say is applying for pathology is going to be no different than applying for any other specialty. So you know, whatever specialty, if you want to do surgery, if you want to do GP, inevitably now that you will have to show some commitment to it in some ways. But your local pathology department will almost certainly be happy to have you for a day, involve you in intermittent bits of audit or whatever it may be, just things that show you are interested. And if there's conferences or anything that you see or events at the college that are on the website, then all of these things will just give you more material to add to your portfolio, is what I would say. It's not, the portfolio thing is not necessarily what you've got, it's just to demonstrate that you have an interest and have looked into it, really.
I think as well, Mike, I think all clinical experience that you've got as a foundation doctor is going to be very relevant because everything can be traced back to a pathology link as well. So I think it's about having an appreciation of what the specialty is about, but also recognizing that all you're doing as a doctor already is extremely useful for what you're doing as a pathologist going forward.
Okay, that's brilliant. Thank you. I think Jessica also wanted to come in on that. Jessica.
Yeah, so for chemical pathology, it's always easiest just to try and call whoever's your duty biochemist and find out what opportunities they have in the department. But also you can do audits to look at blood tests or any other point of care testing or anything, because when the Royal College says 70% of diagnoses involve pathology, most of those are chemical pathology. So it's very easy to do an audit that involves a test of some description, for us at least. So that's another thing you can do.
Brilliant, thank you. I think Dilek also had a comment to make.
Thank you, Rachel. Yes, so I'm a histopathology trainee, and I echo everything that Professor Mike Osborn and Matt have both said. So similar to the person who asked this question in the Q&A. So I did F1, F2 and didn't really know what I wanted to do with my life. So I took a year out and just did some work in A&E. And it was then by chance I came across a poster for, a taster week in histopathology. And I just did that taster week and was actually really amazed by what I had just discovered, and decided to do a little bit more sort of taster weeks with them on an ad hoc basis. But I didn't necessarily do any pathology specific projects. I had just used what I had done for foundation, so any audits or any other extra teaching events that I had done. So you don't have to have anything specific to pathology. There are lots of transferable skills that you can demonstrate at interview and in your portfolio. So don't worry about it being specific to histopathology per se.
Brilliant, thank you, Dilek. So we've got a question for Emma about, are there any ST positions open in February each year? And can you do the RCPath Part 1 before you're in a pathology training scheme? Dilek, are you happy to answer that, or would you prefer me to pass it on to Mike?
Yeah, I'm happy to take that. So I don't think it's possible to do the Part 1 before starting a training program, say being a histopathology trainee. Because you need a lot of pathology experience and you need to know the basics very well, and you need a lot, or at least 1 year's worth of histopathology experience under your belt before you can sit the exam. And it's not like surgery where actually doing the exams before you become a trainee is advantageous. It doesn't really work like that in pathology. It's more that you're doing the exams to confirm to yourself that you're progressing as you are expected for your level, and actually confirming to yourself this is the career that you want to do. And there are only 2 exams in pathology. Yes, they are, especially Part 2 is quite tricky, but I would not advise doing the Part 1 before you become a pathology trainee, because in all honesty there is no point, and it'll be too difficult.
Brilliant, thank you. So this is one I was wondering whether perhaps one of the non-histopathology specialists might like to answer this one. Any advice for a first year to develop their CV but also keeping their options open for specialties? Would anyone like to answer that? Ian or Thomas, perhaps?
Yeah, I'm happy to jump in on that.
Thank you.
If you're thinking about a pathology specialty or not, and the advice is going to be quite similar. So you need to find yourself somebody in a department local to you who's got a project ongoing that isn't just too niche. So if you're thinking just from my own specialty, a lot of the quality improvement projects or audit work we do are pretty much applicable across specialties. So if an F1 or a trainee phoned me up today and said, Ian, what have you got going on that I could do to build my portfolio? I said, well, we're doing a quality improvement project in regards to penicillin delabeling and infection management. It's pan speciality. There's always going to be work going on that by, getting your hands dirty and getting involved, you're going to be demonstrating that you're somebody who is interested, outgoing, and have the skills to apply to any specialty to do. So my advice to everyone is pick up the phone and be interested and ask nicely, and most people will be there happy to support.
Brilliant, thank you.
Yeah, from hematology, yes, I suppose because we are half a clinical specialty and half a pathology specialty. So there are plenty of opportunities to do clinical stuff, which you can use for hematology, but certainly can use for other specialties as well. Just thinking things like neutropenic sepsis audits has a crossover with microbiology, infectious diseases, and hematology. Doing some acute medical work, doing some intensive care stuff. These are all things that are very adjacent to hematology in their clinical settings. So yes, there are plenty of opportunities.
Brilliant, thank you. I was wondering if I could ask one of the microbiologists. We have a question here from Pavin, who has a visual difficulty, and they were wondering if it will impair their ability to become a microbiologist. I don't know whether Ian or Isabel could take that.
I was going to give Izzy a second to jump in, but it's too slow and I'm too chatty, so I'll dive in. The answer is no, because just like Mike said in the beginning, even within each discipline of pathology, we're a very broad church. So one small limitation, or one thing that you're working around, is never going to stop you from having a fulfilling career within a microbiology specialty. And as each specialty evolves, the use of technology evolves too. Within our lab, we've got an iPad set up from a training perspective that we use to record interesting gram stains and other microscopic images. And you could easily think of a solution by which you would be just as functional using that iPad to look at stuff under the scope as you would be doing it directly. So I would not let anything like that put you off. But if you wanted a bit more reassurances, do as everyone suggested, go and reach out, do a taste today, and get your hands dirty, feel how you'll fit into that speciality, and that's going to be the best way of finding out if it's going to work for you long term.
Thank you. I think this next one is going to be either Matt or Mike, because somebody has asked about artificial intelligence, asking, the way AI is developing, is pathology becoming redundant as a specialty, not a real concern? It suggests that I understand other people can prepare the samples, but how likely is it that AI would be able to analyze the data a pathologist normally would? Thank you. Looks like Matt is willing to take this one on.
I can take this one first, Rachel. I'm sure Mike might have a view as well, but no. So when new things come into specialties, there's always a fear that maybe they're going to replace you and you're not going to have a job in the future with that. That's absolutely not the case with AI at all. The same fears we had to have with molecular pathology, and look at it now. It's a tool in our toolkit that we use to help us in our daily work. And it's the same thing with artificial intelligence. Certainly within the specialty of cellular pathology and even neuropathology, the ability for using AI programs to count and recognize the number of positive cells in a sample that can make a huge difference to the grading of a particular tumor, and therefore the treatment of the patient, will make a huge difference to our practice going forward. Because if you ask 10 neuropathologists what the score is on their proliferation index for a case, they will all give you a different result, and that will have an implication for the patient. And there are many different examples of where this can be put into practice. The ability of the AI programs to recognize the percentage of immune cells within a brain tumor can make a big implication for particularly whether it's identifying if it's an immune hot tumor that might benefit patients. It's an evolving area, and research, there's a lot of research going on related to it at the moment, but I think it again is going to be a tool that we can use, and it's not going to replace us. And we as medics and scientists, we have that important clinical perspective as well of recognizing when a result is really important to feedback, and other things related to that the AI systems won't be able to do.
Brilliant. Thank you very much, Matt. Did you want to come on that, Mike, or are you happy to leave it to Matt?
I completely agree with what Matt said, particularly in the sort of media, in the next 50 to 100 years. In 500 years, we may be talking about different things, but in the foreseeable future, it wouldn't stop me going into pathology. I think AI is going to probably help generate more work for pathologists rather than less work in a good way, if you see what I mean. I think it will remove lots of the monotony and difficult things, exactly like Matt said, and will leave you to work at the sort of top end of your diagnostic envelope. I think it's a very, very positive thing.
Indeed. Would anybody else like to comment on that? Because I'm perfectly aware that histopathology is not the only specialty where AI is mooted. Dilek.
Sorry, yeah, just a general sort of comment about AI is that I think AI is coming into our lives in all specialties, all sectors. It's going to basically be global in the next sort of 20 years if we're thinking that far ahead. And just like Matt and Mike have said, it will help us, it will help remove a lot of the monotony in our day-to-day job, and also it's going to get to a point whereby industries and individuals who are not using AI will probably be at a disadvantage. So I don't think that you can pinpoint a particular specialty and say, oh, you know, AI is going to take over all of radiologist jobs or all of pathology jobs. I don't think it's that simple, or it's necessarily that clear cut. And I think personally, it's going to be an exciting era that we're entering into. And just like we had the Industrial Revolution, we're probably going to have an AI revolution. It's going to change our lives for the better. So I think we should all be excited about it rather than frightened of it.
Beautifully put. Jessica, would you like to come in as well?
I just say that obviously quite a few of the pathology specialties still do clinics, which will take a while for AI to start taking over. And also a lot of the chemical pathology job is knowing about why tests don't work, when they're going wrong, what's interfering, and AI will still have those problems. It hallucinates. You'll still need some, even if there will be some AI part of there, you'll still need to know when it works, when it doesn't, and how to do that. So there'll still be plenty for us to do.
Brilliant, thank you. Did anybody else want to come in on that, or shall I move on to the next one? Okay. I'm sorry, I think somebody one for you, for Matt again. I'm hoping to apply for histopathology training for the next year, and I'm interested in genomics. Is it possible to be a specialist in genetics within histopathology?
Oh, firstly, that's fantastic. And it's great to hear someone is interested in genomics and thinking about cellular pathology, because I'm sure Dilek and Rachel and Mike will agree, it's very much a part of our daily routine now. Certainly my role in neuropathology, a subspecialty of cellular pathology, every day we're getting molecular results coming through and analyzing them. And certainly when I first came into it, I hadn't looked at sort of molecular or genetics since my first and second year of medical school. So it can be a steep learning curve, but it's very much an exciting period within this. And you can certainly, there are ways of, ensuring you get specific training in molecular pathology as part of the curriculum within the college. And if you want to focus that within your specialty, there are ways that you can do that. And certainly some of the cellular pathology specialties are very more focused perhaps than others on molecular components of it, but that's something you will travel along on the pathway through training and be able to explore more of. But it's certainly something you're going to be exposed to practically on a daily basis within it.
Indeed, I think genomics is most definitely here to stay. Now there's a particularly interesting question which I'm rather enjoying, because I think everybody can get involved in this one, in that somebody's thanked us for the amazing talks and would like us to explain briefly what the training pathway for different fields of pathology is. So I was wondering if perhaps somebody from each specialty on the panel might, or indeed everybody, might like to comment on this one. I don't know whether perhaps we might like to start with immunology. Anne, would you like to possibly come in on this one?
Yeah, of course. For immunology, the curriculum's changed recently. So from 2021, immunology used to be separate and up to 2021, and since then we've joined forces with allergy. So it's a bit confusing, but essentially you would do IMT, sorry, you can tell how old I am. You do IMT, but it's a group 2 specialty, so you would only need to do the first 2 years, and then you would apply for a post. And at the moment there are 2 streams within the training program, both of which cover immunology and allergy. But there is a longer 5-year stream for people who want to do the lab aspect of immunology on top, which is what I'm doing at the moment. But if you didn't want to do that and you wanted to focus on the clinical immunology and allergy side of things, then there would be a 4-year stream. You apply for both in the same interview, which is quite handy, and you can actually apply for both. So yeah, sorry, I think I might have made that very confusing.
Not at all. I wonder whether possibly, well, actually, Matt, would you like to tell us about neuropathology?
Yeah, so well, in relation to with the so to get into neuropathology, first of all, you start off as a cellular pathology trainee. So you'll do your first and second year with all the other cellular pathology trainees, and that will become the point where you can make a decision to change into another specialty. So that's where you can apply then to do either neuropathology training, forensic pathology, or even pediatric pathology at that point. So that's if you again go along the medical route of this. Of course, to work in neuropathology, you don't necessarily need to be a medic as well. So you can go through the biomedical biomedical science route, and you can work in the lab on the lab side of things, whether that's in the molecular pathology side or the tissue processing, and even with the tissue cut up as well. So that is entirely based on from biomedical science interactions with that. So there are a variety of different options that are available to you within the specialty, and it's very flexible in helping to cater to what you require from your career.
Brilliant. Who would like to maybe go next for their specialty? Jessica.
So chemical pathology has recently changed. We used to have chemical pathology versus metabolic medicine. Now it's all chemical pathology. You apply after IMT2 or multiple ways. So we're very flexible. IMT2, PEDS core training, anesthetics core training, ACCS core training, finish GP, broad-based training with any of the different exams there. So once you've done those, you need to, for IMT2, have done PACES. For the rest of them, you need to have passed whatever the core bit of the exams are for those specialties. Then you go into the 5 years of chemical pathology training, which tends to be in mostly based in a single center. Occasionally, you'll have to rotate to try and get other experiences, but generally, it's very targeted rotation. It's not just randomly rotating.
Excellent, thank you. Thomas or Dana, would you like to maybe tell people about the life in haematology? So it's a trainee.
Can you hear me now?
Yes.
So I don't think hematology is that complicated, and there aren't many routes. You essentially enter hematology training after your IM2 year, and it's 5 years of training in all aspects of hematology, and you do your 2 exams during that period as well. And during that period, you can take time out of training to do a PhD, an MD, or to just have an out of program, a year out of program. That's it, essentially. That's the training in hematology.
Fantastic. Ian, I don't know if Isabel's still having problems with her sound, but would one of you maybe like to tell everyone about microbiology?
Yeah, so unless Isabel jumps in and takes over. So very similar to the other specialities, and as far as through your foundation training, through the first 2 years of IMT, and the slight difference in infection training is that you get to select your disciplines that you'll CCT and be a consultant in at the end of your training when you apply. So you have the opportunity to select either clinical microbiology, medical microbiology, or a combination of medical microbiology and infectious diseases, or medical microbiology and virology, or infectious diseases and general internal medicine, or infectious diseases and tropical medicine. So you have that opportunity to pick a mix a bit in regards to what your particular areas of interest are and where you wish to have your career going forward. And that's the one thing you just have to be slightly mindful of, is that we ask you to make a choice in that regard at the beginning of your specialty training. There is always some flexibility to change through your CCTs, but yes, it's a good idea to have a bit of an understanding of where you want to get to before you start when you're applying to infection high specialist training.
Fantastic. I was wondering whether, Dilek, would you perhaps like to talk about histopathology training?
Yes, of course. I'll just say histopathology is the same as cellular pathology in case anyone gets confused about that. So it's a 5-year training program, and the earliest you can enter it is after you've completed your foundation year training, so F1 and F2. It's 5 years. You do 2 exams, part 1 and part 2, at various stages. The only thing I will add is that for the first 2 years, autopsies are mandatory, so you have to do them. You have to do 20 in your first year and another 20 in your second year, and then it's optional, so you can drop the module if you don't want to continue with doing autopsy pathology. And I just thought I would mention that because that can be quite a sticking point for some individuals. But I don't think, if you really don't want to do autopsies, but you really like the rest of pathology, I don't think that should stop you. But yeah, in a nutshell, 5-year training program.
Brilliant, thank you. There's quite an interesting question here about, I'm going to direct to Mike, saying, what is the difference between histopathology consultants and biomedical scientist consultants in terms of work and responsibilities?
Okay, that's a good question. So the most obvious difference is the training route. So a consultant histopathologist who is medically qualified will have to go to medical school, do foundation years, and then go onto a training program for histopathology, as Dilek has just outlined. A biomedical scientist would usually do a degree in an accredited biomedical science type degree. There are a variety of ones that can lead into biomedical science as a career itself. They would then go on to join a department as a biomedical scientist and work their way up the biomedical scientist grades until they reach, it's usually about level 5, where they would start to have the opportunity to develop reporting. There are 3 areas of reporting now, which are skin, gynae, and GI. They're likely to be more in the future. They would then have to do the course, which is like a pared down. It's a pared down version of histopathology because it's only focusing on that one area. That's not to say it's any easier. That's not to say it's any less significant. It's just you're only going to be doing GI or gynae, one of those things, rather than all of those things. You'll then take the various stages of that and pass that. That can usually take, technically it can take 3 years, but quite often it can take about 5, because remember, you're probably working at the same time. And then you'd have the qualification to report independently as a biomedical scientist. I've nearly finished. You could then, there is now the option though, if you reach biomedical science grade level 7, probably without going into the independent reporting grade, of moving into basically the clinical scientist mechanism. And in the future, there will be potential to do the full FRC path in histopathology, just as there is the potential for clinical scientists to do FRC path in many of our other specialties, for example, immunology, clinical chemistry, hematology, and you would then end up with FRC path and be exactly equivocal to a consultant histopathologist. So if you're a medically qualified histopathology consultant or a clinical scientist with FRC path, you are essentially equivocal, and you would be reporting as a consultant histopathologist. If you are a biomedical scientist, you would be reporting in a specialist area, and the level to which you were reporting would depend on the needs of the department and agreement in those areas and so forth. So they are different things, but equally important, and it depends what people want to do and their position they're coming from and so forth. A bit complicated, but I hope that explains it.
Brilliantly, thank you. This is a question actually directed to Anne, somebody's wondering if there are any good resources for immunology and allergy, since they found it quite challenging at medical school.
Yeah, so did I. The British Society of Immunology has some really useful resources on it. So there's a website and also obviously an organisation too that does regular conferences and things. But they have what's called like the bite size. I can't remember the exact title, but perhaps I can share my email with you at the end. But essentially, there's a bite-sized part of its website where it's got little chunks of learning resources, which are really digestible, really short, very easy to read. So I'd highly recommend those. There are some useful books for later, but at this point, I probably wouldn't, want to overwhelm you, and would probably recommend actually using any resources that medical schools suggested, because at this stage you don't really need more than that. But to be honest, there's quite a lot out there in terms of general articles, especially from the allergy point of view. There's quite a lot that's been in the news recently, so kind of keeping an idea of topical things that are going on is quite useful too, and might be a good starting point. For example, the MRAID recall might be a good one to start having a look at.
Fabulous, thank you. Sorry to come back to you, Mike, but I think this might be one for you. Somebody's asking about roughly perhaps how many training posts there might be in 2024, apparently, very specific.
In which specialty?
Histopathology.
Okay.
Sorry, that was why it was you. I should have said that.
Okay. Okay, so the number fluctuates and is governed by the government. Did you say in 2024?
I did.
Okay, so if I had answered this question, okay, if I was to answer this question this morning before 9:30, I would have said there will be about there's usually close to 100, it's about 94, 95. But the government workforce plan for the medical, for healthcare is being released, and there is being released on Friday, and there's a lot of talk about the fact that it will increase training, as this is no secret because Rishi Sunak said it on the TV on Sunday. There will be more posts and more training, and therefore possibly there will be more posts in histopathology and all specialties going forward in the very near future, but about 100.
Brilliant. Thank you very much. To be honest, we may have reached the end, I think, of our time allowed for this. And I would like to reassure anyone who hasn't had their question answered that the team behind the scenes will be answering your questions later afterwards. They will send you an email. So I was wondering if perhaps it might be a good moment to thank all our panelists for their engagement. Is there anyone from the panelists who wants to say anything, who feels I've left them out at all, or had anything they wanted to add before we move on? No. In which case, I'd like to hand back to Matt, who I believe is going to talk to us about the BDIAP. Is that correct?
Thanks very much, Rachel. So I'll just share my screen, so hopefully you can all see that. So as Mike mentioned at the beginning, he is the secretary for the BDIAP, and I am the deputy meeting secretary. So we have two hats in the meeting today, but they are very kindly and generously sponsoring the event tonight. So what I wanted to do is to give you a little bit of information about the organisation and what its roles and responsibilities are. It's more specifically for those who may be thinking about a career in histopathology, first of all. But specifically for foundation doctors, we've got an exciting membership opportunity for you as well. So there are many opportunities where we can provide bursaries to help support you to attend BDIAP events. And these are a variety of different things. So it could be the joint BDIAP and the Pathological Society meetings. In fact, there's one going on right this moment up in Liverpool. So a great opportunity for you to actually go and attend, listen to some of the interesting talks that are going on, explore some of the research going on in histopathology, and maybe even yourself present a poster or even submit an abstract for a talk as well. There is also opportunities to attend the molecular pathology and the approach to cut-up study days, which I organise in March every year. And again, each year we have a group of foundation doctors who join us for these events, who want to get a little bit more of a background in both of these areas when they're really set on a career in histopathology and entering the training programme. And there are lots of educational materials that are put up on the website for the events that we organise. A lot of them are recorded, and also PowerPoint slides, and information is all available to you as a member. And there are also, we can provide very useful links to trainees and the counsellors for particular taster day opportunities. And also if you just want some career advice about, you're thinking about the specialty, want to get a little bit more information, or even about related to applications and interviews. So plenty of opportunities to engage with us, and to talk to specialists in particular specialties in cellular pathology, and also just to get some advice about career opportunities going forward. So for medical students as well, there's also opportunities to get access to student elective bursary opportunities. So you may be wanting to explore a project or an opportunity related to histopathology. So there are opportunities we can support that. And also, again, same advice. If you want to contact us to explore what a career in histopathology can offer you, then you can get in touch with us and the other the BDIAP trainee counsellors who can give you some advice related to this as well. And the foundation membership that I just mentioned, this is completely free. So if there are any foundation doctors on the call, or even other doctors in other specialties, if you're interested in joining, then do visit the website for more details, and we'll look forward to receiving your application related to that. And also you'll see along the bottom there, we've got representation on Twitter, on Facebook, and also on Instagram as well. So do follow us and hear about the latest events that we're organising. And if you want more information specifically about the membership, grants and bursaries, or upcoming events, then do follow the QR codes here on the screen, or visit the website www.bdiap.org. Thank you very much.
Thanks very much, Matt. And thank you very much as well, again, to BDIAP for sponsoring tonight's event. It's really appreciated. Right, I'm going to share back my slides now. So if you think that you'd like to explore your interest in a pathology specialty a little bit further, and I hope that you do, as we discussed in the Q&A, I would strongly recommend that you organise your own taster day or days or a week in a department that you're interested in working in or that's convenient to you in your region. And to do that, we do have a way to help you, which is that we can provide you with an official college letter to the head of department of your choice, asking them to support your visit. And if you'd like a copy of the signed letter, drop an email to the college team and they will send you a copy, and that may help to facilitate your taster day. You don't have to use the letter, of course. I'm sure many departments will be delighted to take you and without a letter anyway, but it is available if you think it would be useful and you'd like to use it. Before we wrap up, it's a good time to highlight some awards and competitions that we run, which may be of interest to you. We have an annual Art of Pathology competition. This is currently open for entries. It's a great way to explore pathology in new ways, and there's a very generous prize in different age categories sponsored by Sonic Healthcare. There's also a Science Communication Prize, which is open until the 17th of July this year. So another one to get your skates on for. And this is awarded to a pathology trainee or foundation doctor or medical undergraduate who has shown excellence in their science communication activities. And finally, we have 2 essay prizes, which run every year. The Hugh Platt Foundation Essay Prize for Foundation Doctors and the Paolo Domizio Undergraduate Essay Prize. We get some fantastic entries for these. These are last year's winners, who were Anime Shetty from the University of Cambridge and Soumya Singh from the Essex, Bedfordshire and Hertfordshire Foundation Schools. You can read their work on the website, which I strongly recommend because they are fantastic essays. And lastly, I just want to highlight our small grant scheme for medical electives for medical students and also for veterinary students. You can find details on the website. The current round will close for applications on the 31st of August, so please do apply. We absolutely would welcome applications to that scheme, which we run in partnership with those other societies that you can see on the right-hand side of the screen. And with that, we've come to the end of this evening's event. Huge thanks to all of our panelists and speakers, and to the President for joining us, and special thanks as well to Matt Clark for all his work putting the mystery case together, Rachel Rummery for chairing the Q&A panel so efficiently, and to Carla and Kristen, who've worked very hard behind the scenes, organise everything so brilliantly. And lastly, thank you very much to you all for joining us. I really hope that you've found it useful and have been inspired to continue on your pathology journeys. Have a great evening, everyone. Goodbye.